I'm Dr. Athmaja Thottungal, and it's such an honor and privilege to talk to you regarding sex and gender differences in pain and pain management on behalf of the European Society of Regional Anesthesia and Pain Medicine on the day of World Day of Regional Anesthesia and Pain Medicine. Mind the gap in pain. This is very important because the gap is not only in pay but also in pain. That is why in 2024, IASP celebrated it as a global year for educating and increasing the awareness regarding this gap. We say children are not small adults. That applies to male and female as well. Women are not small men. The chronic pain is a gendered epidemic. Fibromyalgia, migraine, and autoimmune pain conditions, which are nearly 100, that affects women 3 to 9 times more than men. The biological foundation in the difference is two hormones, which is estrogen and testosterone, which makes the pain processing pathways in the female and male brain different. It also affects the pain threshold, the pain processing, and analgesia response. There is an anatomical and physiological difference as well. The human body composition is different. That includes the muscle tissue, fat distribution, and bone density, bone mass between the male and female. Even the biomechanics is different. In pain perception point of view, in a male brain, the peripheral injury is transmitted through the central nervous system, especially the microglia in experience. But in a female, this is controlled, specifically the pathway is controlled by the T cells, which is starting in the periphery, and it is a part of the neuroimmune response, and that is experienced in the central nervous system later. So all these physiological differences affects how each drug is metabolized, excreted, and it imparts the effect on the human brain, which is different between male and female. The musculoskeletal system difference is a huge part of pain management, as the bone density, bone mass, as well as the skeletal difference makes a huge part. The biomechanics will be different, and this affects the incidence of various joint problems in male and female. The best example is the Q ankle, which is different between a male pelvis and the female pelvis, which affects the incidence of knee pain and osteoarthritis in female, and osteoarthritis of the shoulder and the shoulder pain problems like a frozen shoulder around the menopause in women. The pelvic anatomy, innervation, and also the density of the nerves are different between male and female, and that is one of the reason it contributes to the sex-specific pelvic and menstrual pain patterns as well. As women, we go through 5 P's of our physiological roller coaster, which is puberty, pregnancy, perimenopause and menopause, pelvic pathologies like endometriosis, and hormonal imbalance like polycystic ovaries, subfertility or infertility. Once a male attains the puberty, the diurnal variation is very minimal in the hormone fluctuation, but in a female, on a day-to-day basis, the cyclical changes happens, and this is exaggerated during the stages of pregnancy, perimenopause, menopause, and also underlying cause of many of the other pelvic pathologies. This affects the medications or the drug metabolism effect, and also how pain is experienced and processed in a female brain. The other big difference is the sex and gender, along with the cultural biases in pain recognition and treatment. Male physicians rate women's pain as less severe and also more likely to say that it is mainly psychological. This unconscious bias leads to delayed diagnosis and inadequate treatment in female population. Many pain conditions are considered as normal. The best example is menstrual pain, labor and postpartum pain, or menopausal changes and the musculoskeletal changes that happens in the menopausal age group. And this is accepted as a norm rather than seeking any specific treatment. Another classical example is atypical chest pain of cardiac events. Because the male chest pain is described by the male physicians and it is transmitted as atypical, many physicians don't even recognize a heart attack in female population, even though it is the number one cause of mortality and morbidity in women after menopause, and women contribute more than 50% of the population. All widespread pain syndromes are considered as psychological or says it is all in your brain. The social, professional, and the personal bias influences the pain assessment and management in the form of lack of awareness among the public and the professionals, and also the societal and the structural biases, considering many pain as normal, and the cultural and the lifestyle influences matters as well, especially for a female, the societal pressure to perform other duties or prioritizing care of others makes it is more difficult for them to access pain management services. The sexual bias in biomedical research is a huge part as well. The opioid paradox, where it says women metabolizes opioid differently and we require 30 to 40% higher doses for equivalent analgesia, but yet prescribed less opioids. And male models of both animal models as well as human models are still used for many protocols that are still practiced in our medical practice. Until mid-90s, it was not even mandatory to include females in the research, and female-specific research is still underfunded. Psychological difference is another important factor because men have 52% more synthesis of serotonin than women. This is one reason why depression, anxiety, psychological trauma, and stress is more prevalent among women, which are strongly associated with the chronic pain experiences. Special consideration in the low resource countries are one, they may lack even enough health professionals available, limited training opportunities for pain management, especially sex and gender sensitive care, and lack of national policies and limited availability of painkillers like opioid all contribute to this. There may not be even multidisciplinary services available or supported by the government. So in future, if you want to proceed and apply inclusive, equitable strategies for pain management, what we need to do is identify these current gaps in the clinical guidelines and research and rectify these by future research priorities and also research specifically looking at the sex and gender differences in making newer policies and new pain paradigms. The policy development is one important aspect where the education also needs to be included, both physicians, patients, and other policymakers. The priority of the future research should include the sex and gender differences as well. The principles of the new pain paradigm should start with the assessment where it has to become sex and gender sensitive. The pharmacological management and the interventional management should include the sex gender as a part of the management context. And even the non-pharmacological treatment like lifestyle medicine interventions should be sex and gender specific as well. The future research priorities, this should be mandatory that any intervention that we are researching should have that sex and gender differences as the priority and inclusion criteria. Also, there is female gender, female sex specific condition needs to be prioritized as a research priority as well. In regional anesthesia, we need to think about how we need to change our block techniques, dosing, and monitoring based on the biological sex and gender differences. We all are trying very hard as anesthesiologists, regional anesthesia, and pain physicians to reduce the incidence of chronic persistent post-surgical pain. As it was published by DC Rosenberger and team, the risk factors, if you look at it, the major factors are patient factors and pre-existing pain or undertreated pain. Anesthesia General anesthesia or regional anesthesia as an anesthesia option does not make a huge difference, but the analgesia option and treatment of pain makes a huge difference for the prevention of persistent post-surgical pain. So, if you look at them separately as patient factors, the sex and gender specific and also changing the modifiable factors makes the biggest impact for the prevention of persistent post-surgical pain. This is also evidence-based as they published this article in BMJ 2025 where 186 RCTs were included and they looked at the usual care and the outcome, which is very poor. But if you include the lifestyle factors and also which can be made into sex and gender specific, the outcome will be way much better and more desirable. So, sex and gender difference, equality versus equity. We are not looking for equality, but equity. For that, we need social justice where the inequity can be addressed. So, as take home message, I will say sex and gender difference has got a huge impact in every aspect of human life. Pain management should shift from the WHO analgesia ladder to personalized holistic pain management. Focus should be on equity, not equality. And the lifestyle factors are very important and it can be applied irrespective of the sex, gender, socioeconomic, or geographical differences. And final few words. Please believe and validate patient's pain report regardless of sex and gender. And avoid normalizing pain as normal or hormonal, or please don't say it's all in your head. Use a well-structured life course, looking through a life course lens in assessment and make a tailor-made, holistic, multimodal, and culturally appropriate treatment available for them. So today, as a part of our desire to have equity, access, and relief from pain, I request all of you to our call to action, which is we commit to form evidence-based, equitable pain management that is recognizing and addressing sex and gender differences. Thank you very much.